It's now live.
All right, thank you. So we are live, and I think Sanele has just come in, so I might be meeting him into the Zoom platform at last. I think he could sort out that problem. All right, thanks again for joining us. This is Dr. Ntlagani Pogumede Talks Health podcast. In the past week, we looked at various topics around healthcare matters in South Africa. It is my view that we need to create discussions around health issues. This will help us understand basic concepts of healthcare. This show today is going to assist both the user of healthcare services and the providers of healthcare. And let me introduce today my guests, that is Mr. Chris Maxon, as well as Dr. Sanele Mandela, who's joining us to discuss one of the less discussed topics in healthcare, and certainly in the face or social media platforms, and that is the health economics. So welcome, gentlemen, and welcome to this show. Thanks for joining us. Chris.
Hi, welcome. Hi, morning, Dr. Kumete. It's a great pleasure to join you on this becoming famous platform and a much needed topic that we need to discuss. We hope that we will add value to the people who are following and those who want to follow for the future episodes to come.
Thank you very much. Dr. Mandela? I don't know if Dr. Mandela is still struggling to join in there, but I can see that he's still online. Let's just wait a little bit to get him on board. And if it doesn't go through, then I think we will just proceed with our interview today. But his microphone is off as well as the video is off. So if you can hear me, Dr. Mandela, please turn your microphone and your video on so that we can actually be in contact with you. But otherwise, I think we should go ahead with our conversation today. So South Africans in general were not very involved in healthcare matters in the past few years. And with the new developments, obviously, the society understanding more politics and getting access to new information, and also trying to understand about the national health insurance, we see more and more people engaging in health discussions, even in social platforms. Not to mention the public consultation that was done by the chairperson of the Health Portfolio Committee throughout in different provinces to try and get the views of the public. Now, there are a few issues that I think that today we need to actually highlight and understand about healthcare matters, and that is the issue of the health economics, or people would call it economics of healthcare, what it means and all of that. So today I'm joined by Chris Maxon. And before we start, I just want Chris to tell me exactly his exposure to health, his background, what did he train to do, and where is he working at the moment? Chris, tell me more about yourself.
Well, I joined the Department of Health many years ago, actually. I worked in the laboratory services for my first 10 years of joining health as a medical technologist. I trained in what is called clinical pathology, which includes your microbiology, hematology, my lab, and chemical pathology. So I worked in Itindale Hospital, your hospital.
Oh, great.
Also worked at Nkandla Hospital, and then I went to some private labs. After that, I came back and joined the department. So at the time when we joined, laboratory services were still under KwaZulu-Natal Health. So I've been with the department since 1995. But I guess for an accident of competence, I guess, if there's such a term, I ended up joining what is called communications, because in the department there was what we call now Strategic Health Program, used to be called PAU, the Provincial AIDS Action Unit. So there I was in stakeholder management. I guess they noticed my writing skills, and then I was attracted into communication. And I've been in communication and also being a spokesperson of the department for some time. And eventually now working in programs, especially HIV and AIDS, mother and child, TB, male circumcision. and HIV, which I think I'm falling greatly in love with. That's how my working career went. But the pursuit of excellence, trying to better ourselves from yesterday, I've always continued to study. I've studied a lot of management, and I now have a master's in development finance. Interestingly, my topic was around what you will regard as health economics, because I was looking at the efficiency in HIV, in ART, what is called antiretroviral spending. Are we spending efficiently? And that was my study, and looking in Pietermaritzburg. So that's the long and short of me. And now I'm doing some postgraduate leadership studies with the University of KwaZulu-Natal.
Well, that's quite a long, biography that you're giving us there, and it is giving me an indication that you have been around for just about 20 years in the Department of Health, and you have been exposed into various sort of like aspects of healthcare. And I think that I could have chosen a better person to actually talk about health economics. As a topic that really people are not really very, so I think that today, let's get some time they entail and all of that. I mean, to start our discussion today, I mean, for someone who've never heard of what health economics is, and how would you explain it to them in the simplest terms? I'm not sure, Chris, if you can hear me there, but I'm just struggling to hear you now.
Is concerned with the supply and the consumption of health and healthcare services. So we are looking.
Sorry about that, but Chris just left the Zoom platform at the moment, and I think that he's trying to join in now, and I hope that we can explain that question. Chris, are you there? And I can see that you're talking, but nothing comes to my side.
Yes, I'm back. Can you hear me?
I can hear you now. Yes, I can. Loud and clear.
My sound is okay. Okay. Really concerned itself with are we producing, are we giving people the services that they need, and are people the health that they want? That's basically what health economics is about.
Yeah, I'm just very concerned, Chris, about
discussion between the health economists and
I'm just going to check with the people on Facebook who are actually watching this, if they can actually hear anything that you just said, because I'm really struggling to hear from my side. Let's just hold on a minute there, Chris, and restart the show a little bit. Are you there, Chris?
I know my weather is terrible here.
All right. So is it possible that perhaps maybe you can maybe call in or something like that, or switch off your video and leave your audio on?
Yes, how is this now?
Can you hear me now?
I can hear, I've always heard you.
You've always heard
Hello.
me. All right, I can hear you now loud and clear. All right, Chris, are you there?
Yes, I'm here.
All right, okay, let's recap just a little bit there. And obviously, you know, the question that I asked, I'm not sure if people that are live on Facebook actually got your explanation on, you know, the simple terms of your explanation on what health economics is. If you don't mind, please just give us a summary of what you just said, because I didn't hear a word of what you said. Just summarize that topic for me.
In summary, it simply says when an economist speaks to a doctor, what kind of service do you provide? The doctor will say, I provide everything that my patient needs. But an economist will say, no, you can't describe it in those terms. You must tell me exactly what is it that you provide. So, and the doctor will say, if my patient comes with a flu and also complains with an ear, I will also provide medicines for an ear. And the economist will say, no, but that's a waste. So health economics is really that discussion between a doctor and an economist. An economist would look at, are we providing at the lowest cost so that, but still benefit the patient?
Yeah. So I mean, we talk about these health economics, but why is it important for us, whether it's a healthcare provider or a person that is actually receiving healthcare, to actually understand this?
But there are two reasons why. For healthcare providers, is because the resources that we have are not always, will not always be sufficient. But for the user, as much as the user does not pay, they are aware that they need to get the services that they require, not more than what they need. Because the moment they take more than what they need, they are not taking for themselves, but taking it from someone else who in future will not be able to get that medicine. Or that's
Yeah, I can see that Dr. Sanele Mandela is actually with us now. I'm just wondering if he wants to come in on that and maybe start by introducing himself and his background and all of that. Dr. Mandela, can you hear me?
Yes, Dr. Gumede, I can hear you. I think you can hear me.
Yes, welcome to the show, Dr. Mandela. Today we are talking about health economics, and I would like to get an understanding, your understanding of your background, you know, what you do and all of that, and what involves you with health economics.
Thank you very much, Dr. Gumede, and again, good morning, Chris. I've been listening to you the whole time, gentlemen. It's just that I was not able to come through. I don't know how. I'm sure Mr. Chris as well is having a challenge on that side, because I'm struggling also to hear him. But basically, my name is Dr. Mandela. I've been involved in healthcare from 2013, when I finished my community service in Newcastle, my community service in Dundee, and also my internship in Newcastle complex in Matateni and Newcastle. And after that, I went to Pomeroy Community Health Center, and subsequently I became the accounting officer in that institution, where I was the CEO and the medical manager. I have since moved to start as a health data chair in Cuba, and I'm currently doing my master's in public health, executive master's in public health in Peking University, specializing in global health and international health economics. So this is a very interesting topic for me, and I hope that we clarify some of the challenges that people actually need to understand in terms of healthcare, and as a base of actually a base of economics, and also understand how the scarcity problem is tackled within the healthcare system.
All right, thank you very much, Dr. Mandela, and thanks again for actually joining us on this discussion. And I know that some of the terminologies that are used within the health economics are quite very unusual, and for people to get explanations of this, it becomes very imminent and important. But obviously, this is the purpose of today's show, is to explain some of these terminologies. And obviously, Chris has mentioned the reason why the user and also the provider of healthcare needs to understand the topic of economics. But when I was doing the research prior, when I was preparing for this discussion, I actually came across very interesting terms that I think that our audience today needs to actually hear. And one of those terms is efficiency. And Chris, would you tell us about efficiency? What does this mean, and why is it relevant for our department and our public to actually be aware of these terminologies, both from the point of view of the provider and also from the point of view of the actually receiver of healthcare?
Well, efficiency, in the beginning, I think in April, was it February, that the minister announced the health budget. So, and he gave us that money that he gave us at national, and then some money goes to provinces. What efficiency means is that money, will it be used for the purpose that it is supposed to do, in a way that the people that it is intended to service will get value from the health system. So, well, if I want to use an academic term, efficiency is about whether health resources are being used to get best value for money. So that's what it is. So it simply means, for a person was in Changa, when they go to a clinic in July, will they get a medicine that they need? We always see this medical aids, when a person, you are told, no, you have used up your funds. That is what efficiency is about. Yeah. That when you go to your nearest clinic, at no point you should go there and not find what you want to do. So if you're a health economist, you need to use certain theories and certain calculations to ensure that the resources that are implemented are used up to provide a service, will deliver the service at the lowest cost. That's basically what efficiency is about. And that's what we all need to look at. When I employ a nurse, do I need 5 nurses or do I need 1 nurse in order to do 1 HIV test?
Yeah.
So because if you employ 5 for something that 1 person can do, that's inefficient. But if you employ 1 in order to do 5 people, that's very efficient.
Chris, you're talking about this thing of efficiency, to say that we need to be able to be wise when we use the resources that we have. Now, the question that I have, Dr. Mandela, is that, I've heard people talking about being effective at work, like I am effective at work. And health economics on the side, they put emphasis on the word efficiency. Is there a difference between being effective, efficiency, being effective, and also, doing something that is expected of you to do?
Yeah, actually, there is a difference, but at the same time, Chris, I think he's explaining it very, very well. Talking to actually the fundamental reduction in the amount of waste resources that are used to produce a given number of goods and services. In this case, is how much we are using effectively the resources that we are given. As CEOs and the medical managers, this is exactly what faces us each and every day in terms of healthcare services, where you will then have to debate sometimes the use of doctors that will work at night, and also that you will have to hire from outside the institution, having the doctors that you have that are working from 7:30 to 4:00 during the week. So now, when you make those decisions to actually get extra resources from outside the institution, which will be very costly again, when you look at it, that is, you get sessional doctors. So what happens is you need to make sure that the 80 hours of the doctors that are within the institution that are working there 40 hours a week, that means from after 7 to 4:00, all of them, they have exhausted their hours at night, so that you are then able to cater for a doctor who needs to come in over the weekends as a sessional doctor to complete or to assist in the institution. But at the same time, you might find that when you have added that extra doctor, you would find that the doctors are now maybe doing 54 hours or 60 something hours, which is no longer efficient and effective. So that is the balance of issues when you are in the healthcare services, and what Chris is actually explaining. So practically, that is what it is. But you need to go to those details to actually look at the hours that doctors spend, so that you are then able to move around and balance the number of hours that they work at night when they're on call. So basically, that is what Chris is explaining, and I'm just trying to put a practical position or a practical picture on how efficiency will work in our sector.
Yeah, thank you very much, Dr. Mandela. Gentlemen, I think you've explained that terminology very well, and we've also then looked in terms of effectiveness and being efficient as in a different terminology. But the next term that I want so much similar to it is the concept of equality. What does that mean, Chris, in terms of health economics? What are we talking about here when we talk about equity?
Well, once again, just like effectiveness and efficiency, it's not just equality, because where we tend to make a mistake is to confuse equality with equity. Equality simple means we are all on the same par. Disregarding everything else. But equity simply means, especially in health, it simply means everyone is able to get the health service that they need, irrespective of where they come from, how much they earn, and be able to live a longer life that they desire for themselves. That's what equity means. But we can be equal as citizens. You know, in South Africa, we are all equal. That's what our constitution says. But the services that are being provided to us are not equitable, because it depends on the amount of money that you have in your pocket to get the best service. So equal is, you know, everyone is equal. We are all from born in the God's image. But when I get sick, it depends on the first thing that the ambulance would ask me, do you have a medical aid? You know, so that's when we start discussing issues of equity.
Yeah.
So the reason behind the whole national health insurance is to ensure that there is equity in health delivery in South Africa. So that's where I didn't want to discuss equal alone without comparing it with equity, because unless we understand it in that context of the difference between the two, we miss the point. Go on again.
Yeah, thank you very much, Chris. I think that's a very important, and I think I just want us to have a look at this from the more practical point of view. And, you know, in terms of the delivery of healthcare to our population, is there anything that is distinctive that will define these two terms in the actual practical sense at a hospital, Dr. Mandela?
Thank you very much, Dr. Kumete. And again, excellent, Chris, how you have unpacked it. The issue of equity is very important, because you see, in terms of healthcare, why it is important, or it is different, is that healthcare has got a tendency of not being there are issues of uncertainty in terms of healthcare. So role of equity and the need is very important in terms of how we deliver healthcare. Okay, equity will arise from the access of social determinants of health, you know, specifically about from the issue of wealth and all those issues. That would be the issues of equity. And it means that giving patients care they need when they need it. That will be the issue of that addresses the issue of equity. So then the issue of how now it's unpacked in terms of how you bounce it back to equality is just the general norm in the society, where people must have access to all the issues or the facilities that they need to have. Like, for instance, bringing clinics or primary health care centers or to the community is very important, and it facilitates the availability of these resources closer to where people are, which is very important in terms of for government, in terms of service delivery and access to the issues of healthcare. So these issues that Chris is explaining, it's practical for us in terms of having this the access to healthcare services of the population, with number of healthcare professionals that you find in the system, so that they can have then access to healthcare services, and therefore you can then actually look at the equity of how that healthcare service, that healthcare service is provided, including how you link them to other healthcare services that are more advanced. Like, for instance, you will have patients coming to
Yeah, Dr. Mandela makes a very interesting point about the social determinants of health, that you can't be healthy unless you have got access to a safe and housing. You can't be healthy unless you have got good supply of clean water. So equity is also not about just providing healthcare, access to healthcare services, irrespective of where you come from and how much you earn. It's also about ensuring that where you come from, once we have treated you in a hospital, we don't take you back to a place that created the disease that brought you to the hospital.
Sure. I mean, Chris, that concept in itself, I think it's not something that is new to us. We know of, the concept of primary health care to prevent disease and to address issues around what we call the social determinants of health. And we spoke about this in the previous podcast as well. But I mean, you've explained it nicely now. We know about equity, we know about equality, but I just want us to take a little bit of some time and to go back to now health economics. And I need you to school me here. There are three terms, that is utility and cost, the opportunity cost, marginal cost, and benefit. Would you mind going through each and every one of those concepts and briefly define to us what those things are in health?
Well, utility cost, basically what it does is to give a monetary value to the benefit that is given by the service that we provide. Let me make an example. For an example, when we give people ARVs and we want to extend their lives in the number of years, that in economics can be given a monetary value. That's what utility cost is monetizing the benefit that is given by a health intervention. So you give it a rand value, the rand value of the number of years, the quality number of years that we have given you because of the treatment that you get. Let's say, for example, because you have hypertension, you would have died maybe in 3 years. But now, because you are on treatment, you are not going to die until natural death kicks in. So that can be given a monetary value. That's what utility cost is about. I'm not sure if that was clear.
Great.
Yes, and the opportunity.
Clear, Chris.
Yes, when we talk about opportunity cost, is the loss, is the cost of the loss opportunity for choosing one over another intervention. We are right now in COVID. The opportunity cost would be, for an example, the cost that will attach to not immunizing babies just because we have been focusing on COVID, or because there were restrictions, mothers could not walk around and take children to clinics to get immunized. So that cost is called an opportunity cost.
Yeah.
So the cost of choosing one instead of the other is called an opportunity cost.
Quite interesting, isn't it?
Yes. Now,
actually, to add on that, and how bad is the issue of opportunity cost, you will also look at what we have done in our country when HIV came in. We ignored non-communicable diseases and we focused on HIV. That is opportunity cost. The resources that we actually put for HIV, it did cost us the big problem now that we have in terms of NCTs. So basically, that is exactly in practicality what Mr. Chris is explaining when you look at it from a point of view of healthcare. Sure. That is why now you see campaigns, huge campaigns about redirection of to non-communicable diseases, and what COVID has also exposed in terms of patients that were dying because of these comorbidities, specifically diabetes and hypertension. This is, you see now a lot of people that were discovered during COVID that were not even diagnosed. And some of them, they were not controlled on treatment or with non-communicable diseases. But if they were controlled, like majority of the patients that had COVID, that had controlled diabetes, they actually survived. So these are the issues that I think it's very practical for us when it talks to the issues of opportunity cost, of how much we have invested on HIV and ignored non-communicable diseases in the past in the past decades. And this is the price that we paid when COVID came in.
Yeah, this is very interesting. Actually, I never looked at it at that way. And Dr. Mandela and Chris Maxon has actually explaining these things very clear to us. And it just makes me to think, yesterday I was in an information meeting and we were looking at the immunization of kids, and it came out very clear that during COVID, the focus was on an adult rather than on a child. And that was an opportunity lost, because obviously after COVID is gone, we're going to come back and having to sweep, or rather maybe to sort of like mop all the water that is leaking from the neonatology side and the pediatric side now, because we've literally, just forgotten about those services. But Chris, just tell me, is it possible that we can actually make all of these things to coexist, and also to come up with strategies that address these challenges for us to be able to do this thing?
Well, yes, it is. One of the greatest things that we did during COVID, if you remember very well, we sent out community healthcare workers and our tracer team to visit homes, to do screenings. And the only thing they focused on was to screen for symptoms of COVID-19. If you know the close correlationship between COVID-19 and TB, you still wonder why they couldn't ask similar screening questions for TB. Or why didn't they ask the parents if the children have been immunized? Or ask those who are in chronic medication if they've got enough stock? So all those are opportunity costs.
Yeah.
In the same way, so it's also about what is called is vertical approach in program implementation. One of the writers some time ago said that, well, those who like vertical, it's because it makes political sense, but it does not address the health needs of the population. But if we do an integrated approach, that's when we begin to address the health needs of the population. And that's the crux of it. And I'm sad, but I'm going to say it is a leadership issue.
Yeah.
That what do we think when we get there? But once again, an economist would have advised that, you see, now the same people will have to be sent back to the same houses to go and trace TB cases. The same people might need to go back and look for those kids that need to be immunized when we begin to see cases of polio or measles re-arising. And again, maybe when we have another extreme wave of extreme TB cases. So an economist would have said, why didn't we use the infrastructure at the same time and the resources that we use so that we get the maximum benefit at the lowest cost?
Sure. Thank you very much for that. And I'm just reading a comment here on Facebook. My wife, Lynn Gumede, is actually commenting that this is such a very valuable information. Doctors and who are in management or hope to be in management must be able to hear this. How do we spread this information for everybody to actually understand what is at stake? Do we talk about this more often with our doctors, with our managers, with our public, so that they can understand some of these important things?
My view, I thought Dr. Mandela will take it. My view is the first thing is we must change our leadership structures and our leadership culture. We must have what is called a shared leadership culture within the health sector in general. I'm not talking about public only, including private, by the way, so that a sister in a ward understands the economics of her decisions to do one thing and not do the other, or to try and put a drip 5 times and fail 5 times and succeed, and the cost of all these niggles. So until those people understand, so that one of the things is to change the management culture. That's very important that we need to do. But also we need to change our approach to healthcare. We need to begin, I think COVID has taught us, our concern should be the whole population. It should not just be certain people of the population and we leave others to be taken care of by medical aids or someone else, or they will go to their private doctor. Ours, we are a healthcare system of the Department of South Africa, and therefore every South African should be treated equally and equitably, so that it helps the system to respond also in the future. Those are just my 2 points. I'm not sure if Dr. Mandela wishes to add.
Dr. Mandela,
thank you very much, Chris. I think what the latter, what Chris has actually mentioned, the issue of change in terms of our approach. Vertical approach is actually very detrimental, because when you go back again to look at what health economics tries to do, it concerns with these issues related to efficiency, effectiveness, value, and behavior in the production and distribution of these scarce resources in terms of healthcare. So once we approach it in a way that all the time it gives us quick gains, and we then forget about the long-term effects of how we're using these scarce resources, because economics is all about the scarcity of the problem. It's always about that. And it's got these very basic 3 questions that needs to come up all the time when you are attending to these healthcare problems. The issue of what to produce, the issue of how to produce, and how to produce. So these issues, we need to base it on that, so that we are then able to answer the question that you are asking. That in terms of healthcare professionals, or how do we do this in such a way that people benefit at the end of the day? The healthcare managers and professionals, as Dr. Lynn Kumete is asking, these are issues that needs to be addressed at a level of management. Management, you can imagine management that doesn't have exposure in terms of this type of topic that we are dealing with. We need to structure these things in such a way that we deliberate in terms of giving information to our managers when it comes to these issues, so that we don't make decisions that are popular within the institution. We need to make decisions that are tough, that will make people hate you sometimes, and distribute resources the way that people will sometimes will hate you. But you will have to do this because you've got an understanding, and you know by the time in 5 years' time or in 10 years' time, things will be better because you would have structured things in a better way from the beginning. So sometimes we make these decisions because we are pressured by our colleagues within the institution, the executive committee, and all that. But when you are a clued up healthcare manager, and you know about these issues, you will then bank on certain things, because this is actually banking on certain issues, so that you can then reap the results at the end of the day. So that is how I think it's important for us to look at the approach that we have. A very good example that Chris made is that how many times do we need to go and profile the community? Because we've already visited the household, and we knocked in people's doors, and the community health workers were chased by dogs in this household. But now you have to come back again and do a screening for TB. You have to come back again and do for non-communicable disease. You have to come back again and do it for another search of a pandemic coming in the future. So this is what we mean to say when we say the approach must be an investment in a healthcare system that will make the community benefit at the end of the day. And the healthcare professionals and providers would have had a better analysis in how their interventions are in the future.
Yeah, this is quite a very interesting topic. Obviously, I mean, already we've spoken about efficiency, and then we've spoken about equity, and we've spoken about utility and cost, and we've just explained beautifully what opportunity cost actually means. Just to finalize these terminologies, Chris, marginal cost and benefit, what are we talking about here?
Marginal benefit simply refers to the maximum amount of money a person is prepared to pay for an additional service. Say, for an example, when you eat ice cream until you just can't eat it anymore. they say you have reached that point of marginal. You see, when you have money, you get to a shop and you want to drink coffee, and it costs R1. Obviously, you will only be able to drink 10 or the amount that you have in your pocket. That extra rent that you want to pay in order to get that extra cup of coffee. But in economics, they say, what is interesting, the consumer satisfaction tends to decrease as the consumption increases. You see, as the more you get one of the same thing over and over again, but you are
yes.
The desire for it tends to decrease. So that is what the marginal benefit really refers to. Well, but what is the cost now is that it really talks to when the price that's added when we begin to change. You remember at the beginning, I spoke about, you know, when you go for a medical aid, you have a medical aid, you go and then they say there's a surcharge that must come back around what is called a marginal cost. The medical aid, what goes after becomes a much for yourself, but has not been of your benefit. So for as long as people do not feel, you see, in the public health sector, for an example, it's very difficult to explain it because people just go there and they want to get the service that they need without considering the added cost. But also those who produce the service, if they are not aware, keep on adding and giving without understanding that the more you give, you are adding a cost which subtracts from something else that is more important, that you are taking away from. So that's what marginal cost. I hope I'm trying to explain it as much as possible. But basically, that change in the pricing as you add another service on top of an ordinary package of services is what is called a marginal cost.
Well, thank you very much. Ufanya Naduli, somewhere there is saying that he's enjoying this engagement. It's actually an eye-opener. It's not something that actually, you know, ordinary people would actually discuss and to talk about all of these concepts of health economics and all of those type of things. I think that this is a discussion that actually needs to be taken to our institutions. It needs to be taken to the boardrooms where managers and the decision makers actually sit, so that this can assist them to be able to make the decisions that they actually need to actually make. Now, I mean, it's very important for me to actually come in at the moment and actually to remind our viewers today that actually, you know, the vaccination program is actually back on, as we know that we are in the midst of the pandemic. Therefore, there is a sort of like an electronic registration site that is on vaccine.enroll.kznhealth.gov. I mean, kz.health.za, and that is where people over the age of 40 actually register to get vaccines at the community level. So you need to be able to have access to internet. You also need to be able to have a smartphone or a tablet or a computer for you to access this. You connect into the site, and again, the site is vaccine.enroll.health.gov.za, where you need to go in. Then it will welcome you, and you will need to follow the instructions and put in all the details and the systems that that the system asks you for. And then after that, you'll submit all the information. Then you will receive an SMS with the date and the venue for your vaccination. So it's very, very important for all of us to actually, if we are interested in getting vaccinated, to actually register for us to be vaccinated. So I thought that it was important for me to go through that point before we proceed. Now, you know, I've been in trouble before as a previous or an ex-leader of one of the health facilities. In one of the meetings, I actually spoke about healthcare not being free. And I know that our politicians and everybody who actually talks about health, and when they go to the public, they're like, we are going to give you free health care services and all of those type of things. And it always like lands very harsh, in my mind when I hear somebody talk about free health services. Do you agree with me if I say that there's nothing like free health services?
Definitely. There is nothing like that, Dr. Kumete. There is nothing like free health, unfortunately, because all the things that we have, they are being financed. Remember, I'm sure Chris earlier on did discuss or did mention something about the GDP, gross domestic product of the country. And as a country, we are spending a certain portion of our gross domestic product to healthcare services. So basically, when you're paying out of pocket, when you go to a pharmacy or you go to your private doctor, you are actually paying for the second time because you would have your salary, some money has been taken from your salary to actually finance healthcare services. It's taken to government, and the government then distributed it to different sectors, including health. So in our country, which is a middle income country, we spent close to about 6 to 7%, 6% basically to healthcare in terms of our GDP. And other lower income countries lower than us will spend close to about 6.2%. What does this mean actually? It basically means that if you've got lower GDP, which means the country is poor and all those other issues, you'll find that means the people in that particular country are also not having enough money to contribute for government for it to be able to help to work in the community or to assist in the healthcare services that they give to the community. So basically, there is nothing for free. There must have been some money that is in there for healthcare services to be bought. Clinics are not for free. Medication that is in the clinics, you can imagine at a level of primary healthcare, they are not for free. Doctors that work there, nurses that work there, they are paid every month, and that money is also taken from that very same GDP. So there is basically nothing for free. But I wish, Dr. Kumete, we do this, which will be outrageous, to actually count the even if people come in the healthcare, in the primary healthcare facility, come in at the gate, go to a screening, a screening section, and go and collect their files, and go to a healthcare professional that they need to see that particular day, go to the pharmacy, and then leave the institution. If we can, when they leave, we quantify what they have been receiving inside the facility and give them a ticket of showing how much that particular visit cost that particular day. That will make the public to be aware that you can't take your tablets and not drink them at home, and also throw them away, or also sell them. In other cases, you would hear people that they are selling ARVs and all those things. So these are very important issues that we need to look at. That maybe if we can find a system that quantifies each and everything that they have done in that particular day in the institution, and give them the ticket that, as you are thinking that it's for free, but this is 450, goodbye, and we hope you get better very soon. And that happens to every institution, specifically in our primary healthcare facilities, because you find that people would not want to go to the clinic just because it's a clinic. But a clinic has got the same medication that you can find in the hospital. You know, it's just that maybe they are professional nurses that are there, the clinical nurse practitioners that are there. But these clinical nurse practitioners are taught how to clerk the patient, how to examine the patient, and how to give medication. And when it's over their scope, then they will send the patient to the doctor. So this thing of free is very detrimental in how we utilize healthcare services that we have. I don't know, what is your take, Chris?
Chris, your view?
But yes, the free, it's a very worrying concept for me. Let me start from the user side. You see, there's nothing called free health because its cost is the cost of the other opportunity or the work or the time that you have lost. For an example, taking a day off from work in order to go to a hospital is costly. Some people don't get paid for days off. That's a cost of healthcare. And secondly, imagine umama Odaisa who sells tomatoes. If she takes a day off, the profit or the money that she would have made for that day is lost. That's cost. It brings us to what we call opportunity cost. So that's one on the one side. But on the user side, once again, it talks to the important, I think it's a point that you have raised. Some of these things need to be brought right to the level of delivery so that people understand what is it that they are doing and how costly they are, so that they are able to take decisions that are correct and be able to make efficient and effective decisions. Because this concept of free healthcare is a political concept, which is used for political reasons. But practically, it is not true. It doesn't exist. There's no such thing as a free healthcare or free education for that matter.
Yeah, thank you very much, gentlemen. Now that we understand that concept, to say it is nothing called free healthcare, Dr. Mandela highlighted the issues around the GDP, how much South Africa is actually using on GDP. In another discussion, maybe later on, we need to be looking at comparing South Africa of how much of the GDP we are actually using compared to other countries, and how well we are actually, in terms of the outcomes of health do we have. Then we'll be looking at indicators and all of those type of things. But obviously, that is not the discussion for today. But what really interests me at the moment is to actually know exactly where does the money to finance health comes from, Chris? Dr. Mandela, I can't hear Chris.
I'm sorry, I was cut off.
Oh, yeah, you're back. You can go ahead, Chris.
I see when the wind blows. When the wind blows,
Oh, I see. Can you hear me now, Chris?
I can hear you very well.
Yeah, I'm struggling to actually hear you. Dr. Mandela, can you hear me? Chris, are you back?
Yes, I am. I can hear you very well.
All right, awesome. All right. So the question was, where do we get this money? Where does, do we get the money to finance health if indeed we agree that health is not for free?
But that's a discussion, that's a very deeper discussion that we need to have currently, especially as we prepare ourselves for what we call the National Health Insurance. It's a deeper discussion, and COVID-19 has showed us that depending only on the public purse is not going to be sufficient, and people need to begin to also take some of the responsibility for their own health and healthcare. That starts with their behaviors. Firstly, one of the greatest costs to healthcare is the way that we behave, the way the food that we eat, the drinks that we drink, the way we drive in vehicles, and the sexual responsibilities and all those things that they give us the greatest cost to healthcare. So that's one of the things that we need to address. But when we come to the public purse, we need to begin to define. Currently, there's what is called a health budget that is given each year by the finance minister. That minister which is supposed to provide for healthcare, especially in the public health sector. But we also have medical aids. Our government, me as a public servant, I get subsidized. So if we have a universal quality healthcare, that subsidy needs to be taken away. We also pay for things like road accident fund. To tell you the truth, I don't see the reason. Why should we pay for people who knock each other on roads? And honestly, I don't. And that is one of the things that we need to look at. And there are a lot of other benefits that I think we can review in order to ensure that we have one big pocket so that will benefit the whole country. And I think it will be sufficient if we address all the things that we have discussed earlier. But it starts with ensuring that we provide efficiency. We talk efficiency in the way that we deliver healthcare, and we deliver the services that are expected and only those that are expected. We don't have additional services that people don't necessarily need. You give a person medicine and they are wasting public funds. So those are some of the things. That's where my view, the money should come from. But we can't look at government. We must start looking firstly at ourselves.
That's very interesting. This is sort of like a union, and we need to be putting all these sources of information. It's amazing. You know, I wasn't expecting an economist to actually tell me about, you know, us having to concentrate on behavioral change. Because I mean, behavioral change is such a very interesting topic, and we see even within the pandemic how people are actually struggling to adhere to the preventative protocols that have been put into place. Years ago, when HIV came in, people struggled to even use the protection of condoms and other things. And it's quite interesting to know that actually those have got financial implications to government and to the public as a whole. To actually say that if we don't adhere, it means that we'll have to pay more for the healthcare services unnecessarily. A good example is actually what happened in December, and I know that our MEC for Health actually spoke about this, to say that in December, just because the alcohol was not actually opened full, we had less patients that came into our emergency departments. And that also speaks to behavioral change. So these things are the things that are within our control, that we can actually control, so that we can not waste our financial resources into things that do not matter, and we can actually focus on the things that actually are sort of like health issues per se, and that do not necessarily have to do with how we behave as a population. I think that's a very interesting view on that point. Dr. Mandela, is there anything you want to add on that?
Yeah, I think colleagues, you have covered it very, very well. Thank you very much, Dr. Kumet and Chris. The issue here is that we don't have enough, as we have already mentioned, that economics deals with the scarcity of the resources and how you efficiently distribute them, and effectively so in terms of value of cost is important. And as we know that we have almost 16% of our population that is on medical aid, and the spending in that 16% is very, very, very high. You will know that it's very, very high. So now the majority of the people, that is 78% of the population in South Africa, we therefore use the public service. So the limited resources that we have in public service, if people, they think that they are not, they are getting things for free, or else they are still paying VAT, whereas they are still paying. So there is no one who doesn't contribute to this. So how we take care of our services it's very critical and important. So as we have already mentioned, that public government alone would not be able to finance this, and if the government has to finance this alone, it will not be sustainable. Yeah. And at one stage it will collapse. So the best thing will be to try what Chris has already mentioned, the national health insurance, where everyone will contribute. And therefore, when everyone contributes, we will try also means and ways of making everything to be efficient and calculating each and every cent everywhere when we spend. How are we spending it? We need to be careful in casualty, how many nickels we use. We need to quantify things so that we know exactly and be able to then save. If you have 100 sanitizers in your hospital, you need to know how it's being used and where is it located, and what are the benefits of that sanitizer. Same thing applies with all the other resources that we have. So basically, we all agree that we need to find other ways of financing healthcare services in South Africa. And if we're going to think that it's going to only be tax from government, it's going to be a problem. We need to find other ways of doing it right. And the best way to do it right is actually investing more in primary healthcare, which will actually put us into the in the very competitive environment in terms of saving a lot in terms of our healthcare. Because once the primary healthcare is structured very well and we start benefiting from it, we will know that we'll be having more people that are running Cambridge Marathon in South Africa. We'll be having more people that are going to represent South Africa in the Olympics, because it will be, first of all, a healthy way of living. And second of all, it will create employment for other people that are not in the that didn't take the route of academia to get yourself a job. I mean, you look at soccer players, how much money they make. Look at other sports people, how much money they make. Look at in golf. Look at in athletics. There is money there, which is an alternative in terms of contribution to this very same GDP that will make us therefore invest in the long run back to healthcare and back to the services that we need in South Africa. So a healthy community will automatically give us a better GDP. It's that vicious cycle that is there. So my suggestion would be that we both agree, and we all agree, that there must be some kind of other ways and services and ways and approaches of how we invest in healthcare. And critically important is the investment of primary healthcare and investment in prevention and promotion of health.
Thank you very much, Dr. Mandela. I'm reading a Facebook comment there by Comrade Fanyan Nduli. He's saying, Comrade Chris and Tlaganifo, please let's share such information live conversation schedule so that we can be part of the listenership, because we as healthcare workers, we are custodians of service delivery, especially if we want to advance our COPC. All the content of this discussion is of vital importance. Do you agree with this, Chris?
Yes, I do. Actually, I think you have just gave me an idea that we are beginning to define the next agenda.
Yeah.
The next agenda, if we say NHI is the future, it must start now. And the first agenda point is health finance.
Yeah.
And that for me simply means, one, we need to instill a culture of responsibility and efficiency in the health system, not only at the top management, at the lowest level possible, which means at the gate, at the OPD and wherever. So that is one. Two, we need to attract a leadership that is disruptive that is not just going to continue with what they found. We need new ideas, we need system thinkers, people who are just going to be in it, not for themselves, but for the people that we are serving. So that's the second agenda. The third is to bring in partnership with communities. People need to know, if I binge drink and don't drink casually, the health repercussions of that, this is what they mean. If I drink and drive and maybe do not die in that accident, that healthcare provision that will be given to you for the lifetime will be costly to a number of people who may not have contributed, who may not have enjoyed the drink that you had before you got into your car. One of the greatest things is, how do we reduce costs, healthcare costs? By the way, do you know that the healthcare inflation is higher than the general inflation? It is going for 10% now. So how do we reduce healthcare costs? I think the quickest answer is we instill efficiencies. So we need a lot of people who, the competency that will be people who are also going to be able to give advice on issues, how do we provide services in an efficient way. But we also, and lastly, we need to have the political will to change the laws so that they make it possible that a service is costed at its lowest level of delivery. Clinics cannot depend on hospitals. Clinics should be cost centers in themselves, and the person in charge of a clinic should be able to take financial decisions and be able to quantify the cost of delivering each and every service. And lastly, we need clinicians who are also going to be efficiently responsible. I mean, you can't be asking a patient, do you want a Caesar or do you want natural birth? I mean, you would tell me better that the number of cesarean section has quadrupled.
That's very true.
And if I tell women that, by the way, you can't tell me you've had 4 scissors, do you know that's not good for your health? And she doesn't see anything wrong. And you wonder, are our clinicians efficiently responsible? Because that cost that they are burdening the system with is denying someone some service somewhere. And then people will do and say, it needs a partnership from the next agenda after COVID-19 and what needs to be done. I hope this discussion go on. And as Untuli was saying, maybe we need a broader and bigger platform so that we can take this forward.
Yeah, thank you very much, Chris. Dr. Tsepo Ngale in Pretoria saying, thanks very much, colleagues, for the great talk. He's saying, keep it up for the great job. And I have a question, just a little bit of your time, because I know that we are actually just at the end of our conversation here, gentlemen. But Dr. Tsidiza says here, nice topic, and speakers are touching on real and practical things. I just need to ask one question though. Is medical aid really necessary for the working class? I'll take both your views. I mean, Chris and also Dr. Mandela to respond to this one.
Well, the first thing is what gives rise to a medical aid? That's the first question that you must answer. It is, if people do not get the benefit that they desire, they look elsewhere. And they are prepared, if they know that I'm prepared to pay, I'm prepared. I think I have, by the way, do you know that we have a huge public service, but the out-of-pocket contribution of individuals to the general health is 7% AIDS, and we have such a huge public service. It's quite ridiculous for me. So that's the first question that we need to look at, is to say, there are two things. It's either the benefits that people are getting are not according to what they desire, effective. Secondly, or the healthcare costs are very high. So we need some cushioning. I hear now there is what is called a gap cover.
Yes.
Are rising and are rising ridiculous. There are two things that give rise to the rise of healthcare costs. The first one is the skill that we bring in. I think we employ more people than we need. And secondly is the high price of drugs. And thirdly is wastage. And for me, those are three things. If we address those three things and improve the quality everywhere, public and private, and cap the costs at a particular, government can put a law and say, you can't charge people more than this. Then the answer to that, we'll find that we might not need even normal medical aid and people will be able to live quite better. That is my view.
Yeah, thank you. Dr. Mandela, your view?
Yes, thank you very much, Chris. Actually, what Dr. Teresa is starting is a huge a topic that I hope Dr. Kumete is looking at it as well. But to just give to just highlight how big is the topic that Dr. Teresa is suggesting is that basically, in terms of economics, healthcare is different, and it's different in many ways. I'll just mention a few. First of all, the presence of an extent of uncertainty. I mean, uncertainty in demand and supply for health and healthcare is basically different. Remember that when you go and that is, I'll make an example with a vaccine, for a flu vaccine. If you take a flu vaccine, there is that uncertainty because there is also a possibility that you might get that flu, but it might not be that high. So now what you need to do is you start debating that you need to take the vaccine or you don't need to take the vaccine. There's that issue of uncertainty. And also the issue of diagnosis. It becomes a very touchy, very gray area in terms of our profession that we practice. Secondly, the prominence of insurance. You see, the issue of insurance is used to guide against uncertainty and risk, which also change the behaviors of patients, which is the consumers and also the providers. And remember, there are also incentives. You might also find that you are given more information or you are given more treatment or that is induced treatment that you more than what you need, which also complicates the issue of healthcare. Now, and another issue that I would like to mention is the problem of information. Some health information may be unavailable or asymmetric. It belongs to us as doctors and it doesn't belong to the population, which also basically creates a problem. But why I'm explaining this, Dr. Kumete, I just want to highlight how big is what Dr. Teresa is saying in terms of the issue of if you want to know the reason why you will have a medical aid. So the issue of, I mean, in England, they started NHS exactly after World War II because they had a lot of people coming from war that were not able to cater for themselves in terms of healthcare. So they created that for government so that they are able to provide this healthcare services. Actually, according to my view, what we were supposed to do immediately after 94, we were supposed to start NHI there because at that time, we had a lot of people that actually it was going to make sense for them to actually support NHI and actually do everything that we needed to do to actually get into NHI. But we started having middle class and all of a sudden middle class, they've got a lot of medical aids and they form part of this very 16%. And once they have medical aids, people starting to become reluctant now in terms of is really NHI or is really a system to cater for everyone in terms of equity of what we've been talking about throughout this morning, that it is relevant at this stage because now people have got their small cards that they're able to go to a facility or go to and go to a clinic, a private clinic, and be seen within 2 minutes. And they are comparing on this other side in public service that there is a queue there. So those are some of the things that are actually motivating people to even to look at it as maybe it's no longer, it's not relevant. And it's those things. But I want us not to maybe try not to give these answers now, but to try and say, let's give it a platform so that we unpack it, so that the viewers at the end of the day, I think Chris will agree, so that the viewers at the end of the day, the listeners at the end of the day will actually decide and see the relevance of having a one system where everyone is doing, and also to explain the different types of healthcare systems that exist in the world and that we can actually look at and then compare and what would be best for our country, South Africa. Thank you very much.
Thank you very much, Dr. Mandela. And once again, thank you so much to both of you gentlemen for joining us on the show, Dr. Gumede Talks Health. This is a podcast show that we normally have every Saturday at 9 o'clock in the morning, where we bring you about health topics that are less discussed in our platforms. So just before we close, I just want to check if there's anything at all that you would like to say to our viewers and our listeners about any health issues, or even just to emphasize on some of the health economic issues that we've spoken about today. I'll start with Dr. Mandela, and then we'll close with Chris Maxon.
Thank you very much, Dr. Kumete. And I think first and foremost is that we're very thankful that you have taken the lead on this uncharted territory in terms of discussing healthcare topics that are not discussed in very often in our society, and also to give a different perspective in how sometimes these issues affect our population, and also to give each other more information about the healthcare services and about how we need to be attending issues in terms of healthcare. So that one is very important, and thank you very much, my brother, for doing that. And the second part is that, I mean, people should stay safe and be careful that the pandemic is still around, and we need to practice the basic prevention measures that have been tabled by Department of Health, and also to be careful about non-communicable diseases, because that will be the next pandemic in the near future. And how we eat and how we exercise, those things are very, very, very important, and they are critical. So just in closing, on my side, I think those are the two issues that I think I need to emphasize, because we don't need to get to the third wave of COVID-19. Thank you very much.
Thank you very much, Dr. Mandela, for joining us. Chris?
Yeah, thanks very much for this opportunity. I think this really sets the next agenda when we get out of COVID. This we should not be seen as a chain smash and reboot ourselves, so that we can move re-energized to the future. But once again, we should not see also COVID as a government problem. It is everybody's problem, and everyone should feel obliged to play a role. And this is our health system. But and the last point is to say, let us work all together to build a health system that is resilient, that can be able to respond to any epidemic that should come. But while we respond to epidemic, let us not foment other epidemics in the process. Let us take a new approach, is a public approach, an integrated approach, so that we solve our problem and we create a healthier and a better and a stronger health system for future and upcoming epidemics of the future. And that will require all of us to be prepared and to have a new disruptive leadership. Thank you.
Thank you very much, Chris Maxon, as well as Dr. Sanele Mandela. We've come to the end of our show, Dr. Nhlakanipho Gumede Talks Health. And thank you very much for joining us. And if you have any questions at all, please comment down below on your live Facebook comments, sort of like blog, and ask us any question, and we will be able to consult our guests to be able to provide you with the necessary answers that you need. So I'd like to close the show here, and thank you very much to Dr. Mandela, as well as Chris Maxon, for joining us. Thank you. Bye-bye.
Thank you.